thank you for the organizers of this meeting for inviting me to speak. So now we're going to talk about how we can leverage our God-given gut to treat disorders of acid accumulation. And it's a phenomenon that our laboratory has labeled acid stress. So for my disclosures, I'm a paid consultant of Triceta Incorporated, and this is a company that is developing a polymer, a non-absorbable polymer, to remove acids from the body, and I'm going to talk about that near the end of our few minutes together, and also a PI of one of our NIH grants. So acid is something that we develop in our bodies simply from the way that our metabolism works. So if I can focus you on the left part of the slide, we've got two sources of acid that challenges our body. One comes from our natural body machinery. The other is our diet. So if I can move you to the right on that slide, we look at an amount of acid that I've listed is about 60 milliequivalents per day. Now, there are no standards, no published standards on the amount of acid we should be eating during the day. If you look at what the American Dietetic Association says that we should be eating, what is a healthy diet, and our laboratory has taken those foods and calculated the amount of acid that is taken in, that's about 40 milliequivalents per day. But I've got listed 60 on this slide because that's the dietary intake of the community in which I work. It is a historically red-line community, low-income, primarily black and brown community, that when we look at the dietary intake of the folks that we care for in our community, it is highly processed foods, almost bereft of fruits and vegetables. So we're going to talk about that going forward. But when we calculate the amount of acid that the average person in the diet of the community that I serve is about 60 milliequivalents per day. That's a large amount of acid that is being taken in compared to what the American Dietetic Association says that we should be eating in terms of the food. So let me remind you, there are no standards yet, and we like the word yet in determining how much acid is that's being taken in our diet. Well, this is the type of acid that the kidney has to get rid of. And so what we've learned is that this acid accumulation can cause damage to bones, can cause damage to muscles, and for the purposes of our discussion today, can damage kidneys. And so when we talk about this acid accumulation, the 40 years of our laboratory has shown that this is a continuum. It's a spectrum that we're going to describe subsequently. So this is a slide that is a construct of how we see this continuum or this spectrum of what we call acid stress. So the top row is what we call the ideal. No acid in our diet, and so the kidneys have no need to excrete acid. That doesn't exist in Western societies because the diets that we eat in Western societies are acid-producing diets. What we more likely see is the middle row that's on the slide that you're looking at, where we are taking in acid, but thank God, when we've got healthy kidneys, we can get rid of that acid, so there's no net accumulation of acid in the body. So we call that an ongoing acid challenge, but no acid accumulation. Now, we think that that's a harmful situation, too, because what we see in our animal studies. But we've had ongoing patient studies to see whether or not that's the case in patients. What we're going to talk about today is a net and steady state accumulation of acid in the body. And that typically happens because our kidney function is less than normal, and we're not able to completely excrete all of that acid, and so we have a steady state acid retention. So in this slide, I've tried to depict how we see these two states of steady state acid retention. So our studies show that even if you are able to show complete excretion of the acid, in some patients who have a less than normal kidney function, they still, for reasons that we're trying to explain, can accumulate acid, but it's a mild accumulation and not enough to be recognized by the way we clinicians typically recognize acid accumulation by a decrease in plasma bicarbonate concentration. So these individuals have retained acid, but they have normal plasma bicarbonate concentration, and we're still trying to come up with non-invasive ways by which we can identify that. But the real deal is the second part on the right part of your slide, a major accumulation of acid that we refer to as metabolic acidosis that we can easily pick up on our lab. So that gets us into what is metabolic acidosis. Well, formally, it is a net accumulation of acid that's associated with a decrease in the plasma bicarbonate concentration. So that's the signature manifestation of metabolic acidosis. That's how we clinicians, and specifically we nephrologists, recognize metabolic acidosis, and we now know that that is bad. Metabolic acidosis needs to be treated. And it typically is seen in individuals who are eating a high-acid diet, which is most of us, but they have a significantly reduced level of kidney function such that they're likely not able to excrete all of the acid that they're eating, and so they retain a considerable portion of it. So there are three ways by which we can treat this acid accumulation disorder that we refer to as metabolic acidosis. The most common way that most of us do it is by giving a drug that neutralizes the acid that is in the body. Most commonly, sodium-containing alkali, most commonly sodium bicarbonate. That's an approved way by which we do it. The second way is also an approved way. We can reduce the amount of acid that we take in. That is, to lower the amount of acid in the diet. And we're going to talk about how we do that. But essentially, it is adding what we call base-producing components, like fruits and vegetables. So when your grandmother told you to eat your fruits and vegetables, she was right. That's good for you. And so the third part, though, is the investigational part that we're going to talk about, a way by which we can use a non-absorbable polymer to remove acid from the gut and remove acid from the body. So this is a cartoon from one of our studies that looks at how our stomach produces acid. The stomach produces acid because it helps us to digest food. So in that middle panel there, it constructs a chemical reaction where there is acid put in the lumen of the stomach that helps digest food. But then there's a bicarbonate, my favorite molecule, that gets put into the systemic circulation. And so that then, putting that bicarbonate into the systemic circulation helps to reduce the amount of acid that is in our bodies and to, if you will, buffer or neutralize that acid. So when we give this neutralizing drug, sodium bicarbonate, it reduces the amount of acid that is in the stomach, kicks up the stomach to make more of that acid, which means that you put more bicarbonate, and really sodium bicarbonate, into the systemic circulation. So that's a way by which we neutralize the acid that has been accumulated on board. And so we can then, by adding this bicarbonate to our systemic circulation, we can reduce this acid retention as shown on this cartoon. Now, the second way we can do it is by reducing the amount of acid that we're taking in. And so this is a slide put together by one of my colleagues, Julia Scalia, that shows acid-producing foods on the left part of the slide and base-producing foods on the right part of the slide. Now, if you look at the left part of the slide at the acid-producing foods, unfortunately, it is one of my favorite foods, hard cheeses, is acid-producing. And if you move more toward the right, You look at meats, poultry, and the like, those are acid-producing foods. But then you get on the blue side, which is the good side, at least it's a good side from an acid-base physiologist, more base-producing foods. These are mostly plants, fruits and vegetables, and look at the top of the list, raisins. Per gram, the raisins are the most base-producing food. So in the studies that I'm going to tell you a bit about, we give a lot of raisins to try to reduce the amount of acid that's in diets. So there are a number of ways by which this fruit and vegetable diet can favorably affect this acid accumulation, specifically metabolic acidosis. And this is a slide by one of my colleagues, J.J. Carrero, that is meant to illustrate that. So if I can direct you to the left column that looks at these substances like malate and citrate, that when they are metabolized by the liver, they yield bicarbonate. And they can do so, this bicarbonate, as I've told you, can neutralize acid, and it reduces the need to make these substances in the kidney that help the kidney to excrete acid. Our laboratory has examined these substances, specifically endothelin, aldosterone, and angiotensin II. All of those are substances that help to get rid of acid in the short term, but in the long term, they are kidney harmful. So these substances reduce the level of these kidney harmful agents. If I direct you to the middle part to look at the amino acid composition of plants as opposed to the amino acid composition of animal products like meats, those amino acids, when metabolized, are largely acid producing, but the amino acid contribution of vegetables are less so. So that then means that we have less acid being produced. And if you look at the right part of the slide, the fruit and vegetables also change the portfolio of bacteria in the gut that makes, among other things, have these bacteria make for what we call short-chain fatty acids. And they can also contribute to reducing metabolic acidosis. So 3 ways by which what your grandmother told you to eat can reduce the acid-producing aspect of your diet. The citrate metabolism to bicarbonate, it reduces the amount of amino acids that can be converted to acid, and it changes the bacterial portfolio of our gut that makes for these short-chain fatty acids that are favorable to helping reduce metabolic acidosis. And so you might ask, okay, do you have any proof that what your grandmother told you to eat can actually improve metabolic acidosis? Yes, we do. This is a slide from our laboratory where on the Y or vertical axis is the plasma bicarbonate concentration. On the X or horizontal axis are the 3 groups of folks that we looked at. These are all patients who had metabolic acidosis, usual care, they didn't get any more alkali. The one in the middle, sodium bicarbonate, they got the sodium bicarbonate medicine that I'm telling you about. And those to the right got fruits and vegetables. And we provided these fruits and vegetables to the community that I just described free of charge in such a way to reduce the amount of acid in their diets. The blue bar is baseline. The burnt orange bar is 5 years after follow-up. And so you can see the usual care over time, their metabolic acidosis got worse as shown by a decrease in their plasma bicarbonate concentration. However, we saw an increase in both intervention groups, both the sodium bicarbonate group and the fruit and vegetable group. And they were comparable in amount. So the fruit and vegetable intervention was as comparably effective as the sodium bicarbonate group. So this is a slide that gets into the investigational drug that I've described. It's tentatively called Vivarimer. It is a non-absorbable polymer that binds acid in the gut. Remember I told you that the stomach makes acid, puts it into the lumen of the stomach. This drug, if you look at the middle part of the slide, it shows us, again, how the parietal cell, this active cell in the stomach that makes acid, puts acid in the lumen of the stomach, puts bicarbonate into the systemic circulation. If you look at that blue part there, this drug, vivarimer, binds hydrogen and chloride, so it's removing hydrochloric acid from the body. When these parietal cells see that acid is being removed, they make more acid, which puts more bicarbonate into the systemic circulation. So that's the way by which this non-absorbable polymer treats metabolic acidosis. It is a powder. It has to be suspended in water. You take it once a day, and we get the results that will, as shown on this slide. So when we remove acid from the body, we reduce the acid retention. So this is the third way we've talked about by which we can treat metabolic acidosis. Neutralize it with sodium bicarbonate, reduce the amount of acid that we take in our diet, and now, by this mechanism, remove it from the body. And so it actually helps in increasing the plasma bicarbonate concentration. So this is from one of our studies that we published in 2019, looking at the effect of this vivarimer drug taken for a year on the effect of the plasma bicarbonate concentration. So the vertical axis there is the net change in the bicarbonate concentration. The y-axis looks at the 52 weeks or the year of treatment, and you can see by looking at the blue graph there, significantly increased level of plasma bicarbonate over the red graph, which is the placebo, showing the effectiveness of this non-absorbable polymer that is removing acid from the body and treating metabolic acidosis. So I'll remind you that this acid is harmful to bones, muscles, and also the kidneys. And so this is an effective way by which we can remove this kidney toxin and benefit not just kidneys, but also bones and muscles. So what I'd like for you to remember from the few minutes that we've had together is that these gut mechanisms play a critical role in each of the three ways by which we can treat metabolic acidosis: neutralizing it, limiting the amount that comes in, and removing it from the body. And leveraging these gut mechanisms yields efficacy with minimal adverse effects. So the treatment with the vivarimer I've talked about is shown to be comparable to placebo in terms of its side effects. It, unlike some of the other drugs that you may have heard that treats electrolyte abnormalities, it is not an exchange resin. It doesn't exchange one cation for another. It simply removes the hydrochloric acid from the body without exchanging another cation. And so what we think is that these simple yet effective interventions must be scaled to treat what we think is a high prevalence of acid stress in the populations of individuals with chronic kidney disease. So thank you for your attention. Really look forward to any questions you might have about what we consider to be very exciting work. Thank you.